So we'll start off with a good overall summary of taste, but also I will talk a little bit about overall all local regional therapies because I think these need to be all discussed in conjunction and not separately from one another. So let's start. So first of all, again, remember that care for cancer and liver cancer in particular is always multidisciplinary. Means you have always surgical oncologists, medical oncologists, and hepatologists also involved, in particular in a setting of chronic liver disease. Because liver cancer is a disease that is two diseases in one. You have first the tumor, and then you also have the underlying disease liver that is compromised by the cancer. And while there is not a lot of cirrhosis of etiology of alcohol and steatohepatitis in where you practice, it is mostly viral, so not as cirrhotic as here in the United States, but still the underlying liver is diseased. And so you need to get multidisciplinary care and not see yourselves just as catheter guys who do cool procedures. All right, so the fundamentals of interventional oncology, the fundamental benefits when you explain them to your referrers is that you cause immediate tumor death, means you have high oncologic efficacy. You are minimally invasive, means that you're cost and time effective. You're gentle in a patient experience and mostly don't require general anesthesia and have no surgical scars. And that is very important to patients because what they will remember is that they don't have to have their bellies sliced open. They'll remember that they only have a minimally invasive procedure. You're accurate because you use image guidance, and you have relatively minimal side effects provided you do the patient selection right and provided that you do the therapy right. You're able to treat patients who have no surgical options. That's also very important, and treat them safely. Okay, today I'm going to talk about taste, depth taste, Y90, and at the end a little bit I'm going to throw in also ablation. And just for learning, I'm going to do a multiple choice quiz, just sort of to get you guys on the basics. So the essence of all transarterial therapy, in particular in TACE, is that you have an artery supplying the tumor, as opposed to the portal veins supplying the majority of the background liver parenchyma. And because the supply is different and the tumor predominantly depends on the artery, you can treat the tumor in a targeted fashion, okay? And so when you treat the tumor, the goal is to saturate the tumor with chemotherapy and chemobolic agent, and then to expose the tumor to an anti-cancer agent with high concentration, to then occlude the artery in the back door, and to cause tumor ischemia with blockage of the blood supply, okay? Regardless of all the therapies and all the tumor therapies, you will always use this under image guidance in a catheter-based catheter-driven fashion, so you obtain a DSA and ideally three-dimensional imaging, the cone beam CT. By the way, this is a picture of Fabian in his training in his last year of his fellowship, I think 5 years ago, as he's being advised on how to perform a TIPS, just for funsies. Okay, the goal is to have the tumor killed totally, right? He's dead, Jim. This is a quote from Star Trek, the original series, when the Dr. McCoy was always diagnosing death. So what we want to diagnose is we want to diagnose death in a tumor. Particularly in this case, was a very nice outcome. This tumor was dead after therapy, and the patient could get a transplant and then a cure. Okay, TACE lives in the intermediate stage of HCC. You have mostly multinodular disease with preserved liver function and preserved functional status. You have a well-defined nodules, mostly preserved portal flow, and the ability to access the tumor supply selectively. And by now, the average expected survival for a TACE is over 2.5 years. TACE can be used both as a definitive treatment as well as for successful downstaging or bridge to transplantation. And if TACE is not feasible, then you can always still defer to other therapies. But TACE is usually still the first line. Okay, there are different ways how to achieve embolization. First is the gel foam. This is sort of like a very, very, very cheap embolic agent. In fact, gel foam was invented in 1945, the last year of the Second World War, as a quick hemostatic agent for bleeding wounds on American soldiers. And so you can cut it and singe it to different sizes, custom made. and you can occlude the blood vessels in a less so calibrated fashion, but basically you occlude, tumor supply somewhere in the range of, between like 50 to up to like 500 microns. You can cut it even so big that it's like can occlude a really big vessel. Okay. Important to remember that gel foam resorbs. So because it is gelatin, after about 2 to 3 weeks, mostly it is fully resorbed. Then there are microspheres, symbolic. There are embospheres, embosine, and a variety of different products out there. These are mostly calibrated either to a specific size or to a range of sizes. And so you can occlude a very specific diameter of a blood vessel, but mostly not too distal in the capillary bed. And then there's Lipiodol. Lipiodol is basically a liquid embolic agent. It is poppy seed oil that is iodinated. And when you inject that, what happens is that it goes all the way into the capillaries and casts out the tumor supply, and then it basically penetrates into the capillaries. Okay, all the way distal. So the potency to block the blood supply to HCC is very high for Lipiodol, then also high for microspheres, and slightly less higher for gelatin sponge, but all of the three work very well. All right, let's talk a little bit about Lipiodol itself, which is the most commonly used, very old, well-known, well-studied agent that's been used since the late 80s. In fact, it is an iodinized oil. It's called thiodol. In fact, Lipiodol is a trade name specifically protected by the company Guerbet, but it has been in the past available also by other sources. When you use Lipiodol, you basically create a vinaigrette. A sauce, right? You create basically a water and oil emulsion. You just like when you have a salad, in which you use olive oil and vinegar, you have more parts of the olive oil than the vinegar, and you mix them really nicely into sort of this emulsion, and where water and oil is emulsified. If you let the emulsion stand, it separates again. So, and if you have more vinegar than you have oil, you'll only have oil droplets swimming in the watery phase. And that's not what you want, because the watery phase carries the drug. So you want to have a water and oil emulsion. So at least 2-to-1 ratio with more of the fatty phase. Lipiodol itself is not cleared by cancer cells, simply because the cancer cells in the liver don't have Kupffer cells, whereas the liver background does. And it sort of functions as a triple threat: a drug carrier, an embolic agent, and tumor-seeking agent. Tumor-seeking agent because it has a specific gravity that sort of tends to take it to the higher perfused vessels, naturally so the tumor. Embolic agent we just discussed, and drug carrier is also, we just discussed it because of the emulsion. So it occludes the hepatic arterioles, ideally at a range of 30 microns. It enters the portal venules through the arterioportal shunts, and it is radiopaque. That means it's imageable, means you know where you're embolizing. So it's a hugely important property to have to visualize the deposited material, because you kind of know, not only do you know at the end what you targeted, you also know what you didn't target, and you also know what you targeted sort of unintentionally, such as non-target tissue. You can quantify that using cone beam CT, and you can assess tumor coverage in those images, and you can identify on undertreated tumors, for example, whole areas that you didn't cover. You'll kind of know if you have to bring the patient back or not. All right, when you create this emulsion, which is just talked about, you basically have to iterate the syringe many times and you have, like, while you do this, you have this sort of almost call it, that looks like a lava lamp, where you turn this big droplets into like a very like blood orange appearing sauce, and you have to iterate many times. 10 to 30 times is the recommendation, but also don't forget, when you actually use it, you have to iterate it in between as well, because if you just iterate and then put the syringe down while you embolize the first branch, the rest will separate. So you have to be pretty consistent about manipulating the syringes and iterating back and forth until you have it all covered, and until you have it all constantly emulsified. Okay, so when you have the hepatic artery, the feeding vessel, and you inject Lipiodol throughout in it, what happens usually is that the tumor itself fills, then the portal venous drainer on the back end fills, and then over time it kind of almost like drains out of the tumor a little bit, into sort of diffuses out around the tumor into what I call the corona, or the penumbra, depending on how people want to call it. And what happens, what I believe here, is that you actually cover some of the micrometastatic disease or microvascular invasion directly adjacent to the tumor, which is kind of cool, because then you can treat also, sort of a marginal recurrence, I guess, or in advance. Well, so that was all good, but people at some point were a little bit concerned about Lipido leaking out of the liver and causing systemic therapy, particularly in big tumors, particularly when you do the embolization in a lobar fashion. So what happened was that basically the idea was to maximize drug delivery, right? And while being consistently reproducible and wanting to have long-lasting effects. And so people came up about 20 years ago with drug-eluting beads. And the drug-eluting beads were designed to sort of eliminate the um, non-consistent drug exposure of the liver and lipidal, precisely because people were afraid of the emulsion separating and interventionalists not really consistently mixing these things. And so drug-eluting beads were introduced. And so there was a variety of drug-eluting beads. The key concepts were that people wanted to have a spherical delivery agent with a calibrated size that is biocompatible, means that this is not producing a large level inflammation, and also something that is non-absorbable. That means that is basically remains there as an embolic agent as well. And so these drug-eluting beads were introduced. There are a variety of them. There is small beads, large beads. There's a variety of types, the embosine microspheres, and a variety of things. By the way, all these amazing sort of animations that I'm doing, I actually took with permission from Dr. Arai, who is a genius interventional radiologist in Japan at the Tokyo Cancer Center, National Cancer Center, and he took hours and hours and hours of his time to just create these wonderful animations for teaching. And with his permission, I'm able to show them to you. So when you pack a tumor with drug-eluting beads, basically the principle is that you hopefully pack it so hard that you occlude also the blood supply. And as opposed to the Lepidal taste, the idea is that you actually are able to avoid systemic spillage. So in Lepidal taste, the idea is that you basically treat a tumor, but unfortunately, if you don't properly occlude the blood vessels, or if you have early separation of the emulsion, there is early washout of the doxorubicin into systemic circulation along with side effects. This is particularly true when you do lobar TACE, not so much when you do segmental TACE. And so the systemic adverse events were a main concern. So in drug-eluting beads, the idea is that you keep it all confined locally and that you slowly elute the chemotherapeutic agent over a sustained fashion, about 24 hours, into the tumor, but then you don't spill it into the system. And so the limited washout to systemic circulation apparently was meant to have almost no systemic adverse events. True in theory, and it was true for patients where you treated in lobar distribution and have a great surface area, which leads to early separation of emulsion. Just like you have in a bowl outside in when your salad sauce, and so most systemic effect. But now, when you have cone beam CT and catheters the size of 2 French or smaller, and are able to go directly to the tumor feeder and inject a very high concentration of Lepidol into the tumor while occluding the blood supply on the back end, what happens is that you basically avoid all this massive spillage, and you can close the back door effectively, and then have no more spillage. And so newer studies have demonstrated actually prospectively that the systemic toxicity is no longer a concern. So remember, all these patients have a sort of like a journey. It starts at the ultrasound screening and diagnosis. If screening is not available, unfortunately, they start with symptoms. And so then you present the patients with a tumor board. You often get an MRI or a CAT scan to clarify the imaging, and then you do the TACE. And then you use MRI or CAT scan to sort of see your follow-up and repeat imaging multiple times. And so remember that these patients have a multi-modality, multi-time point imaging journey, and it is valuable to have something on board that is like an imaging biomarker for the tumor, and that is in fact Lepidol in this particular case. Now let's talk a little bit about the indications for your ideal patients for a TACE. Okay, so very important to work in a system where you assess the patient's overall performance. That is usually done with ECOG, like Eastern Cooperative Group, Oncology Group score, which defines patient's performance limitations based solely on its cancer, not just the overall performance. So someone who is in a wheelchair because, I don't know, they had polio or they had other issues, but has no cancer symptoms, it can still be ECOG 0. So it's very important to differentiate for symptoms that are caused by the cancer versus symptoms or debilitations that are not caused by cancer. So ECOG score only and solely focuses on symptoms and complaints originating in cancer. There, of course, ascites is important because it is a sign of decompensated liver cirrhosis or decreased liver function. So your ideal patient has no ascites. Ideally, less than 50% tumor burden displacing the liver. This is because if you end up embolizing a large tumor, you also invariably end up damaging the portal vein, and then you have probably a large territory of ischemia or worse, necrosis, and then you might have actually liver failure. Albumin is an indicator of the synthetic function of the liver, and so you want to have it, a ballpark above 3 millimeters. And bilirubin, if that is over 2 milligrams per deciliter, the problem there is that that is the marker for the excretory function of the liver. And if you have already at baseline limited excretion and higher retention, and therefore probably underlying biliary injury, ischemia, even of the arteries, of the tumor, can still have an effect on the bile ducts. Please remember that the bile ducts are extremely dependent on arterial supply as opposed to hepatocytes in the sinusoids. Okay. Indications should be established using cross-sectional imaging, CT or MRI. You should have a liver dominant tumor, so someone who has like diffuse metastatic disease, bone mets, or lung mets is clearly not a great candidate for local regional therapy. And life expectancy over 12 weeks should be also baseline, because if someone is really about to die, you will not help him with a TACE or her with a TACE, unless you want to palliate for symptoms in pain. Okay. Okay. So patient need to like really understand here about the patient selection and where we stand in absolute contraindications and relative contraindications. So in terms of contraindications, decompensated cirrhosis, including jaundice, clinical hepatic encephalopathy, those are all things that you should not have in a patient that starts at TACE. Okay. Then factors related to HCC, definitely extensive tumors involving the entirety of both lobes are a no-go. Malignant portal vein thrombosis centrally is also no-go. Peripherally, it is still a go. Oh, I hear myself double. Someone may want to mute. Yeah. Peripheral segmental portal vein tumor thrombus is fine as long as you can target it selectively. Impaired renal function is sort of like a thing where you have to be a little bit careful with the amount of contrast you use. But I would say that I'm having a hard time generally blaming 100 cc's of contrast for on AKI. And also additionally, I think that these patients can be prehydrated depending on how bad their kidney function is. But then you also have to ask yourself, is dialysis available? If it's available, then ask yourself, would the patient rather die from cancer, or would the patient rather go on dialysis? It is kind of like a difficult situation to decide, but I feel I'm having a hard time refusing someone cancer care for being afraid to make their kidney function a little worse. Relative contraindications. Obviously, untreated esophageal varices at high risk of bleeding. Factors related to HCC, large tumor thrombus, obviously, and large tumors over 10 centimeters. They can be safely treated with TACE in a staged fashion. Other factors are severe comorbidities. I mean, if someone has end-stage COPD, or if someone has other very significant complications from other diseases, or biliary dilatation and biliary injury, or bile duct invasion of a tumor, those are cases where one has to decide what the benefit might or might not be. Okay. Then the medications. Okay, so pre-procedure medications, always consider that if you have a contrast allergy, you need to pre-medicate. Then if you have, and there's different ways to pre-medicating. I mean, one way is doing the 13, 7, and 1 hour pre-medication. The other way is the 5 and 1 hour pre-medication dosages. Super important to consider that if you have allergy to contrast, 1 hour steroids are not gonna be enough. If you're embolizing not a neuroendocrine, not an HCC, but a neuroendocrine tumor, you have to think about procedural octreotide, because otherwise you have the risk of flush and flushing syndrome. Interprocedural meds, moderate sedation protocol, very important. To administer fentanyl and Versed to make your patient comfortable. Antibiotics, to me, ciprofloxacin is a standard in all patients, and patients who have changed biliary anatomy, for example, status post Whipple or other, or even papillotomy, right? Those need at least 2 weeks of antibiotic care, simply because there is always a risk of ischemia to the bile ducts and then dragging up bacteria, and then obviously a very significant cholangitis risk, superinfection risk. Post-procedure meds, some people prescribe PPIs. I don't usually do that unless I see that some non-target embolic went into the stomach. Antiemetics and NSAIDs as needed per patient, and then morphine-based pain meds are to be enjoyed with caution, given the higher addiction risk. Adverse events. So frequently what happens? So liver failure nowadays is not as frequent if you do it in a selective fashion, but if you do a lobar taste, this is still on the menu. Should never be more than 15% though. And there is obviously different degrees of liver failure. I mean, there's one patient who totally fails liver function and needs to go to the ICU, but there is also a patient who just has slightly exacerbation of a cirrhosis and sort of a decompensated episode where you have new ascites or, maybe increased risk of GI bleeding. So there's a spectrum. Then, obviously ascites can happen both as a malignant ascites when you have a tumor rupture, which should not be the case, or it can happen as a benign ascites, as I discussed, as a consequence of an episode of decompensation. Post-embolization syndrome, I resent calling it a complication. I think it's actually just a predictable side effect. I mean, think about it. If you embolize a tumor and cause ischemia in it, and then it starts spilling all sorts of cytokines, pro-inflammatory agents, and interleukins into your circulation, what happens is that you just eventually will end up having a fever and a white count elevation, and these things should not be mistaken for an abscess formation or infection. This is just a normal expected reaction. And in fact, if you kill a tumor, you should expect that. If you embolize and you have no side effects, no post-embolization syndrome, probably, the chances are you didn't do a good job embolizing. So some people have published that significant post-embolization syndrome is actually positively predictive for tumor necrosis. Tumor abscess formation. So this is rare. Gas bubbles in the tumor are not necessarily always abscess. So, particularly when you do drug-eluting beads over Lepidol, you introduce both gas bubbles as well as you cause nitrous oxide exudations. And so if you see gas bubbles in the tumor, but no white count in the patient, then it's just normal appearance post-haze. I do not recommend draining tumors because you'll never get the drain out. Tumor rupture is very rare and happens mostly in subcapsular tumors and more frequent with very aggressive embolization. And then, of course, you can have hematoperitoneum and seeding. Hepatic artery occlusion is a feature, not a sort of like risk. But obviously, if you over-embolize and have non-target embo or leave too much embolic behind, or if you are too rough with your microcatheter and wire skills and basically dissect it, then you can have a hepatic artery occlusion due to dissection. Portal vein thrombus can always happen after very aggressive embolization. You can have an occlusion. You have to treat it with usually with anticoagulation. Ischemic cholecystitis is not that rare and not that dangerous, provided if it's mostly due to beads rather than the chemoembolic agent. I would not be afraid to embolize part of the gallbladder, to treat a tumor. What I would be afraid of is non-target embolization of the pancreas through the GDA. So again, be very careful with your reflux. We spoke about the rest. I mean, renal failure can happen if an excessive contrast use in patients with underlying CKD. All right, so severe post-embolization syndrome is something that should be known. 5% of patients develop really severe symptoms: nausea, vomiting, abdominal pain, really high fever, leukocytosis, transient elevation of liver function tests and transaminases. This is not rare. I mean, it's 1 in 20, but there is also spectrum. I mean, elevation of AST and ALT to the low hundreds, that's fine. But if you have like thousands, and then you should be worried about an extensive liver injury. So this is treated with supportive care. Can give them steroids, can give them NSAIDs. Basically nothing you can do, but you need to just prepare your patients, sometimes admit them for pain control and management of symptoms. All right, doxorubicin, I want to talk about that a little bit. So this is the very important agent that we use. It's an anthracycline antibiotic. Basically, what we do is we just inject poison at high concentrations. This drug is not necessarily indicated for HCC, but it is an intercalating agent that does DNA intercalation to stabilize the topoisomerase 2, basically no more cell division, no more mitosis, and what happens is that just at a very high concentration that we inject into these tumors, it just acts also as a sclerosant of the blood vessel wall. There is no standard dosing. Flat dosing, I would say 50 milligrams per taste, no more than 150 per liver lobe across different tastes. What is important to know is that the distribution of it and the systemic spillage is dependent on the taste technique. As I demonstrated, it depends on the area that you embolize. So therefore, the larger the area, the higher the risk of emulsion separation and systemic spillage. In drug-eluting beads, it's kind of dependent on the bead size and where you lodge it, but it has more consistent release, as we just discussed. Doxorubicin is is toxic, so you should wear eye protection when you handle with it, and they should try to minimize the risk of handling that. But so when you handle it, make sure you don't spill it. Don't use pneumatic tubes if your hospital has that, and make sure that you have a spill kit available. And when you handle it, you need to be in a spill-proof area, so sort of like slightly away from the back table, separate embolization table ideally. And you must label it clearly and have a protocol to make sure that you know how to dispose of the hazardous waste. So don't just throw it away regularly. The good thing is it doesn't act immediately. So if you get anything spill like in your face, skin, or even worse, the eye, just wash it out with water very properly. So you must have, if you handle the drug, you must have some precautions ready close by. All right, a few questions. What pre-medications is required when you're undergoing local regional therapy for neuroendocrine tumors?
Octreotide B.
Correct. What percentage of patients undergoing TACE experience severe post-embolization syndrome?
B as well. 5%.
Correct. What is the important benefit of drug-eluting beads over CTACE? Offers better survival outcomes, offers less systemic toxicity, can be visualized in cone beam CT, or requires less prep steps in the angio suite.
B as well. Offers less systemic toxicity.
C.
Well, Lepidol offers a kind of more systemic toxicity, as we just discussed. It spills all over the system compared to drug-eluting beads.
C. C.
Requires less prep steps. So drug-eluting beads, maybe I didn't make that clear. Drug-eluting beads actually are the ones that require the less steps because they come prepared, whereas the Lepidol, you have to do the manual iterations yourselves in the room. So there's actually more steps. So let's go over this again briefly. Yes, so Lepidol is thiodized, remember? So it has inherent iodine in it. So Lepidol you can use and you can see on cone beam CT, whereas drug-eluting beads you can't. Okay, so that's the most important thing. Lepidol is an X-ray visible and cone beam CT visible agent. And so when you use Lepidol as opposed to drug-eluting beads, it does not offer better survival outcomes. It's the same with drug-eluting beads. It, in fact, offers a little bit more toxicity, and it requires more prep steps in the angio room because you're handling everything yourself rather than just injecting prepared drug-eluting beads that come from the pharmacy, but it can be visualized. So remember that. What chemotherapy agent is the most frequently used in transarterial chemoembolization?
Doxorubicin A.
Got it. All right, good. Let's quickly look at Y90. Just a quick look. So in a current version of the BCLC, it is recommended as the second line. I know it's not very widespread in Tanzania, Uganda, and sub-Saharan Africa at all, but it is still in the guidelines. So I just want you to be aware of it. It is currently recommended either as a replacement for TACE and can be used as a radiation segmentectomy even in earlier stage diseases. and can be used particularly in patients who have a significant portal vein affection by the tumor. So those who have portal vein tumor thrombus, because radioembolization is less embolic, and so you get less ischemic injury. So there are two products that are being distributed across the globe by two companies. One is the Cerspheres by Certex, which is a company owned by Varian, which again is owned by Siemens. So the Cerspheres are basically not FDA approved, but they're used under humanitarian device exemption program. Versus the Theraspheres are Boston Scientific program, they're FDA approved. Okay, there's slight differences between the two of them. So Theraspheres are glass, the Cerspheres are resin. Important to know is that the Theraspheres have a much higher, much higher dose in specific activity per sphere as opposed to the Cerspheres, and therefore you need far less of these spheres to cover to achieve a certain dose. However, the dose is distributed less equally across the tumor territory, and therefore, the theory is that Certex is less is sort of like more embolic because you need more spheres to deliver the same dose. Okay. Theraspheres is frequently used more in HCC versus Certex is frequently more used in metastatic disease. Just a few things. The mechanism of action is the delivery of a radioisotope that is a reactive product, yttrium-90. It is baked into either glass or resin and has a half-life of 64 hours. So 64 hours means basically, 3 days, you have to have in order to reduce the dose by half. 5 half-lives usually are considered a time after which there is only a negligible amount of dose left. And these are small little particles that permanently lodge in the terminal arterioles of the tumor. They have a beta minus radiation, which is very, very locally aggressive. However, has a very, very small range of penetration, 2.5 millimeters. And so, it doesn't go outside of the tumor. So the patient itself is not a risk to its environment, right? You can do a lobar or a segmental, basically segmental delivery, and patients undergo a slightly different journey. All start with the diagnosis in the tumor board, but these patients have to undergo a mapping study because radiation is very dangerous to non-target tissues, to the lung and to the duodenum and to the pancreas. So you want to make sure that you actually deliver it properly to the tumor. And so for that, you must exclude non-target supply. Okay. After Y90 delivery, you actually do a Bremsstrahlung SPECT, where you can look at the actual distribution delivery, just sort of like treat patients symptomatically if something went wrong and the Y90 got delivered to the wrong place. Patient selection, exactly the same, precautions for an ideal patient like it is for TACE. So I'm not going to go over this again. What relative contraindications are is an excessive tumor burden, compromised portal vein, prior radiotherapy, because previously radiated tumors are not very, very well susceptible to additional radiation. This has a slightly higher ECOG tolerance because the post-embolization syndrome basically is absent. Usually one says that there's a general note, slightly less contrast used because those are two procedures. One is the mapping study and the other one is the delivery. And so between two procedures per procedure, you use slightly less contrast, at least that's the theory. And what is important to know here is that the lung shunt fraction, if you deliver it and you calculate in the shunt study, a higher lung shunt than 20% means from the total of the dose delivered to the liver, you have more than 20% leaking to the lung, and that 20% exceeds more than 30 gray, then you have a real problem. Okay, because then you can really damage the lung and cause radiation pneumonitis. So those are things to know. The mapping study is an angiographic exam. You don't deliver a therapeutic dose. And what you do is you basically just deliver 2 to 4 microcurie of technetium-99 labeled MAA. You have no post-procedure, post-embolization syndrome because you basically don't deliver anything therapeutic. You define the hepatic arterial supply, you calculate the lung shunt fraction, and then you assess where the embolic goes. And there is some really good new data from Northwestern and also repeated from Sinai that demonstrates you don't actually have to do the shunt study if you were doing selective or super selective radioembolization. And so there you just calculate the dose. And I'm going to not go into dose dosimetry here because that goes beyond what you need to know even theoretically, particularly since Y90 is not very widespread in sub-Saharan Africa. Just a few meds, very similar like in taste. The only difference is that people like to do more steroid tapers just to avoid some radiation-induced swelling of the tumor. Other than that, exactly the same meds. Some radiation safety pearls that folks need to know. I think the only really important things for you is that staff involvement should be minimized. Instruments and disposable items should be handled with forceps. You need a room exit survey when you leave. So basically hands, bottom of feet, equipment, anything wet containing patient's blood needs to be surveyed. And the patients really have negative radiation sources after therapy. So it's like very negligible doses that you can measure on a patient from outside. So formally, you need to empty the Foley bag just in the toilet. So there is no additional precautions. Historically, the recommendation was no pregnant visitors, sleep alone, and distance for 3 feet for 5 half-lives. But in reality, we now know that there is no external radiation to a carrier just because the distances of penetration is just so short. Adverse events, why do we do even these mapping studies? Well, gastroduodenitis and radiation gastritis are very dangerous. Obviously, if you irradiate this, the mucosa, you're not going to have a healing ulcer, so you're going to have a non-healing ulcer. So that's very dangerous. Pneumonitis, radiation-induced pneumonitis, very rare nowadays with good dose control. Cholecystitis, sort of not a huge problem, but can result in having to place percutaneous cholecystostomy too. Very unpleasant, difficult to heal. Fatigue is usually self-limiting, and the radiation-induced liver disease is the one that is most commonly presented, but with a delayed fashion. 3 to 6 months is the time period where it presents more often. Okay, what's the cutoff for the lung shunt fraction requiring significant dose reduction on change of therapy? 3, 5, 15, 20?
20%. D.
Got it. What is the half-life of Y90?
D. 64 hours.
D.
64, you got it. So radiation tissue penetration of Y90 beta radiation?
B.
Got it. Good. All right. So a quick run into ablation. Basically, just a very brief situational debrief. Ablation is very early stage disease. An early stage disease. This is a curative therapy that now is used increasingly as a replacement for resection. Okay, there are 2 types: thermal, non-thermal. Thermal types: radiofrequency, microwave, and cryoablation, where you can cook, boil, and freeze a tumor. And then there is non-thermal, where you deliver electric pulses that perforate the membranes of these tumors, and therefore you have a situation where you basically irreversibly destroy the tumor tissue, but you tend to be able to preserve the larger vascular structures and bile ducts. Okay, so the goal of all of these procedures is to achieve a nice ablation zone, not only to kill the tumor itself, but to have like sort of a safety margin around. And you can see here on the patients I treated, you have a small tumor that was embolized with chemoembolization, and you can see it really nicely marked with Lepidol. Then you put a probe down and targeting it. And then what you do is you basically see on the follow-up MRI a nice ablation margin around the tumor, nice safety margin, and that is what is exactly desired. You not only treat the tumor itself, you also treat the micrometastatic disease and microvascular invasion around it. Okay. Now, important to know in ablation is that the safety margin is the product of the gradual decrease in heat around the probe. And so the hottest point of the probe is somewhere like mid in the ablation zone, not at the tip, but sort of like 2 centimeters away at the tip. And this is how the heat dissipates in an ellipsoid, shape. And sometimes in order to target a tumor, you need to do multiple probe placements. You sometimes need to place 2 probes, sometimes 3 probes. And some people actually even advocate not piercing the tumor directly, but doing a bracketing no-touch technique where you, surround a tumor by ablation probes. It's all a variety of different approaches. Most importantly, what you need is you need a margin. And for the margin, nowadays in modern CAT scanners, you use an ablation confirmation software. So that is totally key. Patient selection. So, you want to have patients who are non-surgical candidates, although nowadays we basically say that non-surgical candidates, the ablation is equivalent to surgery. And so patients can be surgical candidates, but can just prefer ablation. The whole thing with the failed systemic chemotherapy is only true for intrahepatic cholangiocarcinoma, for HCC, we treat early stage disease before chemo is even considered. Then ideally, you should have cases where you have 3 nodules less than 3 centimeters up to max of 3, because if you have many nodules, you can't really ablate them very well. And then in cases of tumor recurrence, other therapies, we can use ablation sort of as a troubleshooting instrument. For example, if you have a small margin that you need to take care of after radiation or after TACE, then you can use ablation. Okay, so similar, like with all other therapies, if you have significant extrahepatic disease, you don't want to start treating just this one local occurrence. Everything else, like in like in other therapies that we just discussed, active infection, obviously a total no-go. Here, a tumor abutting a major hepatic duct is a problem, because if you deploy heat energy, you can also fry the bile duct, and so cause significant morbidity. Also more importantly, I think that tumors above 5 centimeters should not be ablated in the liver, but I know that a lot of people out there disagree with me and think that it's safe provided they're in the periphery and not affecting any key structures. All right, complications are slightly different here. If you pierce a needle through the liver, you sometimes can go through pleura and you can have a pneumothorax. You can have a hydropneumothorax, particularly if you damage the diaphragm or heat ablate it and then create an artificial hole, so then ascites can leak into the thorax. That's a disaster. You can have diaphragmatic defects with protrusion even of the liver dome into the chest. Sometimes, rarely, but sometimes can need a surgical repair. Minor complications are, for example, an intentional pneumothorax, where you have to induce air in order to get the lung out of the way to ablate the liver dome lesion. And the rest is, pleural effusion or intraperitoneal hemorrhage. There's kind of minor things. Okay, ablation meds. So very important here, because you're going percutaneously to hold all anticoagulation. These patients need mostly general sedation or deep sedation, because it's very painful, particularly in tumors that are close to the capsule. So those are things you should consider. Oops, and now questions for me. I think, which one of the following is a non-thermal form of ablation? The only one? That should be straightforward to answer.
D.
Yeah, Ari, correct. Which one of the following is a possible complication of ablation but never of TACE? Liver failure, pain, infection, or pneumothorax?
D. Pneumo.
Pneumo, exactly. You go in with a needle directly close to the pleura. This doesn't happen in TACE. Which therapy is potentially curative? TACE, Y90, or ablation?
Ablation.
Yeah, exactly. You have the safety margin, and this is a very early stage disease, so you can cure with that. Okay, this is good patient education source. The II, the Interventional Initiative, has very patient-friendly explanation of all of local regional therapies, including IO, and is very helpful for patients. I have those brochures in my clinic and hand over to patients. It answers a lot of their questions. I recommend that you guys print them out as well for yourself. Okay, quick summary. HCC is important. Over 800,000 people worldwide diagnosed annually. Third most common cause of death worldwide. Rising incidence rates. Globally linked to a lot of hepatitis B in sub-Saharan Africa, as you know very, very well. So a major health threat. You better be well equipped in the basics of HCC if you want to offer your services to your hepatologist. Okay, that's it for me.
Thanks so much, Julius. Any questions?
Sorry, doctor. Maybe I missed a part. How does TACE cause variceal bleeding?
Okay, yeah, very good. Excellent question. So obviously, if you embolize a large territory, right? What you change is the perfusion pressure in the tissue, right? So you embolize perfusion. Let's say you have a lobar TACE, and you have a patient with portal hypertension at baseline, but however controlled, varices at this point, banded or not like excessively distended that they rupture. Now you embolize a large territory in the liver. You have a lot of swelling in the tissue, right? And you cause increased capillary pressure. The portal vein that isn't pumped by the artery is having struggle overcoming that pressure, and so you can have a decrease of flow on the portal vein up to actually a reversal of flow, at least temporarily. And because of this increase in pressure in the portal vein, you can actually pop a varix, particularly in patients with significant portal hypertension. Does it make sense physiologically?
Yes, yes.
Yes. Good. So just be on the outlook, So it's not a frequent occasion, but with patients who already have very high, portal hypertension at baseline, it can happen. So if someone just develops variceal bleeding after a large lobar TACE procedure, yes, you have to link these two together.
Hello.
Yes. I'm wondering what your thoughts are on chemical ablation. So, like in our setting, we don't have thermal ablation and IRE readily available, but we have alcohol, absolute alcohol, and I'm wondering what your thoughts are on use of alcohol for ablation.
Absolutely. I mean, it's great. I mean, it was done as the first ablative modality in Italy. It is very good. It's very painful, as you know, for the patients, but it is very good. It is a reliable and very cheap method to ablate. And frankly, I have to say that I still think that if you don't have thermal, you should do that. Definitely better than not doing anything. And I mean, it's very well studied. Before RFA came, chemical ablation gave us all the initial ablation data. It definitely increases survival, definitely is safe if done properly, and it is cheap. I always said I love it. It's just, we have better methodologies generally, well studied, but it is still done. Even in the United States, there are centers that still do chemical ablation with ethanol. And in Italy, it is not at all done and over and gone. So I strongly recommend that you do it if you have it.
Right. Thank you very much.
Yep.
I have one question, Mr.
You're breaking off. I can't hear you.
Can you hear me now?
Kind of breaking off.
Oh,
Try to speak.
okay. Thank you, Dr. Erki. Yeah. For a great talk.
You're breaking off. You're breaking off. Try to speak directly to the microphone.
Directed to the microphone. I don't know what's going on.
Oh yeah. Okay. Well, now I can hear. Okay. Good.
Okay. I have one question. Thank you for the good talk. I have one question. Do Dr. Robinson, maybe let me reframe the question, like, how long does the Dr. Robinson act? Is it immediately? And how long does it last? And
so yeah, very good questions.
What's the percentage of the tumor DNA and not targeted by Dr. Robinson, and after how long?
Yeah,
and how
very good
take
questions
about it for those patients.
Very good questions. So doxorubicin is thought to induce most of the damage in the first 24 hours, particularly at the doses that we deliver it. But obviously, because it is as I said, like it's an intercalating agent, the effects are sort of like seen not immediately in this very moment. They're probably evolved somewhere in a range of like 3 to 5 days. The thinking is that after a week, basically all of it is just completely eliminated, and the doxorubicin, whatever's spilled in the system, is excreted with your kidneys. Usually doxorubicin does not reside very long in your body, but the effects are thought and seen to be mostly peaked in the first 24 hours. I will tell you that doxorubicin alone probably would not be effective, and that the majority of the necrosis in the tumors are actually induced by the ischemic injury. I think TACE has been always thought as a chemoembolization, so the combination of both, right? So you chemo and embolize. If you do chemo alone, you probably will not target the entire tumor, and if you embol alone, probably you also have residual cells. So what you're doing is basically you are doing multiple different mechanisms of injury to the tumor in order to kill it. Now, the degree to which to which it actually produces a tumor kill has been studied well, and we know now that there are sort of resistant subcell populations of HCC that even can survive high doses of doxorubicin, and then there are basically dormant HCC cells. And so the rates of complete pathological necrosis after TACE vary somewhere between 30 and 50%, unless you really significantly significantly necrose it by ischemia. So it doesn't target all. We know there are resistant cells, but it just adds a lot of value because you do just different types of injury for different cell subpopulations at different stages of their proliferation, if that makes sense.